Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 375 of our pharmacotherapy series, which majors in fluid and electrolyte disorders. The next case reads, R.A.J., a 61-year-old man, is admitted to the hospital because of trauma to his forehead after falling at home. He has a long history of conditions related to his alcohol abuse, liver disease, ascites, seizures, pancreatitis, and malabsorption. R.A.J. complained of abdominal pain, nausea, vomiting, and diarrhea for the past several days. At admission, R.A.J. was confused, apprehensive, and combative, and he had marked tremors. He also had delirium, as evidenced by hallucinations, screaming, and delusions, and he was having multiple tonic-clonic seizures. The medical record revealed that R.A.J. had been taking furosemide for the last 2 months. Pertinent laboratory test results obtained at admission were as follows. Potassium levels of 2.5 milliequivalents per liter. Magnesium levels of 0.8 milliequivalent per liter. Creatinine of 0.8 milligrams per deciliter. Phenytoin was administered for seizure control and R.A.J. was placed on nasogastric suction. Fluid restriction was instituted and furosemide therapy was continued to control his ascites. So my question to you reads, what are the circumstances that have contributed to R.A.J.'s hypomagnesemia? Magnesium body stores are difficult to assess because magnesium is primarily an intracellular ion, and serum magnesium concentrations do not provide an accurate indication of the total body load. In fact, cellular magnesium depletion may be present with low, normal, or even high serum magnesium concentrations. Conversely, hypomagnesemia may be seen without a net loss of body magnesium. Refeeding after starvation will result in increased trapping of magnesium by newly formed tissue, resulting in hypomagnesemia. Similarly, acute pancreatitis and parathyroidectomy can cause hypomagnesemia without a net loss of the cation. The prevalence of hypomagnesemia in ambulatory and hospitalized patients is approximately 6% to 12%. The incidence increases to 42% in patients who are hyperkalemic and to 60% to 65% in those under intensive care. Multiple risk factors and clinical conditions can contribute to the high rate of hypomagnesemia in critically ill patients. Magnesium depletion and hypomagnesemia can develop owing to GI, renal, and endocrinologic causes. Depletion can occur in patients whose dietary magnesium intake is severely restricted and in those who have protein-calorie malnutrition. Also at risk are patients who receive prolonged parenteral nutrition and those who undergo prolonged nasogastric suction. Hypomagnesemia may be present in patients who have increased magnesium requirements, such as pregnant women and infants. Conditions associated with steatorrhea, such as non-tropical sprue and short bowel syndrome, can result in reduced GI magnesium absorption. Insoluble magnesium soaps may be formed in the GI tract because of the presence of unabsorbed fat. Hypomagnesemia can also occur in patients with a bowel resection and severe diarrhea. A rare genetic disorder has also been reported in patients with defective GI magnesium absorption. An impaired carrier-mediated magnesium transport system is believed to be responsible for the symptomatic deficiency, which requires high oral magnesium intake to overcome the defect. Renal magnesium wasting can be caused by a primary defect or be secondary to systemic factors. A rare form of renal magnesium wasting is congenital. Various drugs can induce hypomagnesemia through increased renal loss. Cisplatin, aminoglycosides, cyclosporine, and amphotericin B. Use of loop and thiazide diuretics can also result in hypomagnesemia, which can be reversed with the concurrent use of amiloride or triamterene. Magnesium depletion can be associated with phosphate depletion, calcium infusion, and ketoacidosis. Acute and chronic ingestion of alcohol will result in increased renal magnesium loss. Various endocrinologic disorders, such as syndrome of inappropriate antidiuretic hormone secretion, hyperthyroidism, hyperaldosteronism, and postparathyroidectomy, are also associated with hypomagnesemia. AJ could be hypomagnesemic for many reasons. His long history of alcohol use, malnutrition, and malabsorption may all have contributed to his magnesium deficit. The vomiting and diarrhea that he experienced could have reduced GI magnesium absorption. Use of furosemide and nasogastric suction while in the hospital could also have exacerbated his magnesium depletion through renal and GI losses, respectively. The next question reads, what are the clinical manifestations of hypomagnesemia in RAJ? Magnesium depletion can result in abnormal function of the neurologic, neuromuscular, and cardiovascular systems. Hypomagnesemia lowers the threshold for nerve stimulation, resulting in increased irritability. Typical findings include Chvostek and Trousseau signs, muscle fasciculation, tremors, muscle spasticity, generalized convulsions, and possibly tetany. The patient may experience weakness, anorexia, nausea, and vomiting, as seen in RAJ. Hyperkalemia, hypercalcemia, and alkalosis may be present as well. In patients who are moderately depleted, changes in the ECG include widening of the QRS complex and a peaking T wave. In severe depletion, a prolonged PR interval and a diminished T wave may be seen. Ventricular arrhythmias have also been reported in some patients. I would now like you to outline a regimen to replenish the body stores of magnesium for RAJ, and develop a monitoring plan to assess efficacy and potential adverse effects. The specific regimen for magnesium replenishment depends on the clinical presentation of the patient. Symptomatic patients require more aggressive parenteral therapy, whereas oral replacement may suffice for asymptomatic hypomagnesemia. Patients with life-threatening symptoms, such as seizures and arrhythmias, need immediate magnesium infusion. Because serum magnesium concentrations do not reflect total body stores, symptoms are more important determinants of the urgency and aggressiveness of therapy. The body stores of magnesium must be replenished slowly. Serum magnesium concentrations may return to the normal range within the first 24 hours, but total replenishment of body stores may take several days. Furthermore, approximately 50% of the administered IV dose of magnesium will be excreted in the urine. Because the threshold for urinary magnesium excretion is low, the abrupt increase in serum magnesium after an IV dose will result in increased urinary magnesium excretion despite a total body magnesium deficit. Conversely, in patients with renal insufficiency, decreased excretion of magnesium will place the patient at risk for hypermagnesemia. A reduced rate of magnesium administration and frequent monitoring of serum magnesium concentrations are therefore necessary in patients with renal dysfunction. Oral replacement of magnesium is indicated for asymptomatic patients with mild depletion. Magnesium-containing antacids, milk of magnesia, and magnesium oxide are effective choices for replacement. Sustained-release preparations, such as slow mag, containing magnesium chloride, or Mag-Tab-SR, containing magnesium lactate, are preferred, however. With 5 to 7 milliequivalents, that is 2.5 to 3.5 mmol or 60 to 84 milligrams, of magnesium per tablet, 6 to 8 tablets should be given daily in divided doses for severe magnesium depletion. For mild and asymptomatic disease, 2 to 4 tablets per day may be sufficient. A diet high in magnesium, e.g. cereals, nuts, meat, fruits, fish, legumes, and vegetables, will also help replenish body stores and prevent depletion. For patients with symptomatic hypomagnesemia, such as RAJ, parenteral magnesium replacement is indicated. The magnesium deficit in patients with chronic alcoholism is estimated to be 1 to 2 milliequivalents per kilogram. Because up to half of the IV magnesium dose will be excreted in the urine during replacement, approximately 2 to 4 milliequivalents per kilogram will be needed to replenish RAJ's body store. Magnesium of 1 milliequivalents per kilogram, as magnesium sulfate 10% solution, should be administered IV in the first 24 hours. Half of this amount is given in the first 3 hours, and the remaining half is infused over the course of the rest of the day. This dose may be repeated to keep the serum magnesium concentration greater than 1.0 mg per deciliter. Later on, 0.5 milliequivalents per kilogram of magnesium may be replenished daily for up to 4 additional days. Magnesium can be given IM as 50% solution, but the injections are painful and potentially sclerosing, and multiple administrations are needed. Therefore, the IV route is the preferred mode of parenteral administration. For patients with symptomatic hypomagnesemia who are unstable, such as those experiencing seizures or life-threatening arrhythmias, 16 milliequivalent of magnesium sulfate may be administered as a short IV infusion over the course of 2 minutes, followed by 16 milliequivalent over the course of 20 minutes, then 16 to 24 milliequivalent over the course of 2 to 4 hours. After IV magnesium administration, the patient should remain in a supine position to avoid hypotension. He should be monitored carefully for marked suppression of deep tendon reflexes, magnesium, 4 to 7 milliequivalents per liter, ECG, BP, and respiration changes, and high serum magnesium levels. Facial flushing, a sensation of warmth and sweatiness may result from vasodilation secondary to a rapid magnesium infusion. Particular caution is warranted in patients with renal impairment, in whom the rate of magnesium should be reduced. These patients should be monitored frequently to avoid toxicities related to hypermagnesemia. IV magnesium should also be administered cautiously in patients with severe atrioventricular heart block or bifascicular blocks because magnesium possesses pharmacologic properties similar to calcium channel blockers. In patients who exhibit hypomagnesemia secondary to a thiazide or loop diuretic, amiloride may be added to reduce renal magnesium loss by increasing reabsorption in the cortical collecting tubule. For the initial 2 days of hospitalization, RAJ received 3 milliequivalents per kilogram of IV magnesium sulfate. However, his serum magnesium concentration remained less than 1.5 milliequivalents per liter. So my question to you reads, what might have contributed to the lack of favorable response to the magnesium therapy? The total amount of magnesium administered to RAJ during the past 2 days was higher than the usual recommended rate, that is 4 to 5 days, of magnesium replenishment, leading to renal excretion of a large portion of the dose. Furthermore, the use of nasogastric suction and furosemide have increased the magnesium loss during the replacement period, and hyperkalemia may have reduced the effectiveness of magnesium replacement. In a patient whose serum magnesium concentration does not increase after appropriate magnesium therapy, a 24-hour urine collection to assess magnesium renal excretion can be helpful. A low urinary magnesium concentration is consistent with magnesium depletion, whereas high urinary magnesium excretion in the presence of hypomagnesemia suggests renal magnesium wasting. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 376.